evening, everyone. We'll just let people come in from the waiting room and then we'll get underway. All right, we might make a start. So welcome everyone to tonight's webinar on reprocessing of reusable medical devices in primary healthcare. We are very lucky tonight to be joined by a great group of speakers. So before we get started, I'd just like to acknowledge the traditional owners of country throughout Australia and their continuing connection to land, sea and community. We pay our respects to them, their cultures, and to elders past, present and emerging. So welcome again. My name's Sarah Drew. I am the Program Solutions Manager here at APNA, looking after leadership, education and support programs. I'm joined tonight by Megan Reilly. Megan is our subject matter expert for the IPC program that is funded by Murray PHN on behalf of the Victorian Government. And Megan is the Director of Hands-on Infection Control. She's also a registered nurse and an IPC professional. I'm also joined by my team tonight. So many of you will know Lisa Sinkins. Lisa Sinkins is one of our project officers, supporting all of the GPRCs and PPCCs with their audits. And Deb Kurz, who also supports us with the helpline and all of our education programs for the IPC program. So tonight, you will see in your, if you hover over your toolbar for your Zoom, you'll see there that there is in fact the Q&A. We ask that any questions you have tonight throughout the presentation that you pop into that Q&A. We won't be taking questions from the chat box. So if you put them into there, you can also, by doing that, upvote any questions that you might see in there. And when we get to the Q&A section, we will be taking it sort of from the top down in regards to those questions. So please, if you do see something that is of interest to you, make sure that you upvote it. So what are our plans for you tonight? These are our learning objectives. And you can see there that we're wanting you to develop an awareness of the reprocessing standards, guidelines, and professional obligations. We're going to define the elements of a functional reprocessing environment and describe the key cleaning, disinfection, and sterilisation processes that you should be abiding by. We're going to identify some performance testing, monitoring, maintenance, and validation of reprocessing equipment requirements, and then discuss the documentation, the staff educational training, and the performance assessments that you need to be following as part of the guidelines. So we know this is a very confusing space. And we also know that here at the helpline, we have received lots and lots of questions in regards to reprocessing. We know that there is a number of different standards and guidelines that we need to be considering when we're talking about infection prevention and control. So if we think of that from sort of a hierarchy perspective, you'll see on this slide here that we have the Australian Commission on Safety and Quality in Healthcare, and they are really the big brother. Regardless of whether you are accredited under the RACGP standards, for those of you working in general practice, everyone must abide at a minimum by the Australian Commission on Safety and Quality in Healthcare standards. And we have been into those in previous webinars in regards to the components of that. Next down from that, we've got to consider the AS and NZ standards. And we know that there's one in particular pertinent to tonight's webinar that is currently under review there. And Megan will go into that in a little bit more detail shortly. We then have our accreditation standards, and depending on obviously the industry or the sector that you're working in, will again there depend on which standards that you are then accredited under. So for those of you that are in general practice or office-based, you've got your RACGP standards or 5th edition standards. If we then drop down from there, we have our IPC guidelines. Therefore, general practice, office and community-based practices. Now, there is other guidelines for sort of dental and allied health, but certainly those guidelines there really do cover, a wide variety of settings. And both Megan and myself were lucky enough to actually participate in the review of the IPC guidelines. So we'll talk about that again in a little bit. We then also need to be considering our state and territory guidelines, because although we have our standards, or every state and territory has different guidelines in regards to IPC. And then obviously taking all of these into account, we need to consider how we integrate those into our IPC manual and then translating it down into our daily policies and procedures that we implement. So if we think about reprocessing, so let's now focus particularly on what is section 10 of the guidelines for reprocessing. Under the Australian Commission on Safety and Quality in Healthcare, you can be accredited under the primary healthcare standard in addition to your RACGP 5th edition standards. And you'll see here on this slide, this one is in particular around preventing and controlling infection. The item that we talk to here is around reprocessing of reusable medical devices. And the criteria, which is 3.13, is where reusable equipment, instruments and devices are used. The healthcare service has processes for reprocessing that are consistent with relevant national and international standards in conjunction with manufacturers' guidelines, a process of critical equipment, instruments and devices that are capable of identifying the patient, the procedure, and the reusable equipment, instruments and devices that were used for the procedure, and a process to plan and manage reprocessing requirements and additional controls for novel and emerging infections. Now that probably sounds very high level and confusing to a lot of people, but if we then think of that from the context of the RACGP 5th edition standards, criterion GP 4.1 predominantly is the criterion that looks at the reprocessing of reusable medical devices. And so you can see there in the indicator that it talks to the practice having at least one clinical team member who has primary responsibility for, and I won't read through all of those, but effectively what it's saying is the whole process from start to finish, from an infection control perspective, to ensure that the reprocessing of those reusable medical devices meets the standard. The standard then goes a little bit further to specify very specifically that you must have at least one clinical team member who has primary responsibility for infection control and reprocessing, and that ensures that the practice team members' immunisations are documented. Now, again, we've been through this in a lot more detail in a previous webinar that is available to you if you'd like to go and have a look at it. But it's really critical that you understand all components of these standards and these criterion in order to ensure that you are meeting them. We then drop this down one step further. And I think this is where Megan and I have both experienced a lot of confusion with practices calling recently. And that is the IPC guidelines. Now, what I want to point out here is that these guidelines are intended to help health professionals in office-based practices implement the infection prevention and control procedures. So practices aren't accredited against the IPC guidelines, but may refer to them in order to meet the criteria in the standards for general practice. So I guess an important note that we want to make is that while during the review of the IPC, what was called standards are now called guidelines. So while there were some wholesale changes made when we updated those from standards to guidelines, the updated IPC guidelines do not implement any new requirements that were not already in place via the standards for general practice. The Australian standards and the Australian and New Zealand standards, the national guidelines, including the Australian guidelines for the prevention and control of infection in healthcare, or any other national or jurisdictional legislation. And so we have received a large number of calls where people seem to think that that's all changed. And I can assure you it actually hasn't. So that what the update has done is that it's consolidated and contextualized advice from these sources that is specific to general practice and other office-based practices. We've also added some additional details for practices throughout the guidelines to help you meet those existing requirements. The guidelines have also been developed as a web-based resource to ensure that as updates are required, they can easily be made at the time that national guidelines and standards are changed. The challenge we had with the previous guidelines is or standards as they were called then, they were a printed document. And in fact, there was components that, if we think about changes that occurred during COVID, they actually didn't reflect any of that. So I think, Megan, already we've done 2 changes since they were released in November. So you can see it's about being responsive now. It's a little bit like when the immunisation handbook went online. And the purpose of that was exactly the same. So that as changes occurred, it could be responsive to that. So as we go through tonight, please keep in mind that nothing has actually changed in regards to the standards or guidelines in the area of reprocessing. So with that in mind, I'm going to hand over to Megan and let Megan share her screen and get us underway with the main component of the session. Thanks, Megan.
Thank you. Now, just bear with me. Sometimes it just takes a little bit of time to come up. How's that?
Perfect. Thank you.
Oh, great.
Well done.
Okay. Thank you. Look, I'm very pleased to be joining you from Wajak Noongar country in the southwest of Western Australia this evening. And we've got quite a lot to get through. So I think we'll get cracking on the reprocessing aspect of it. So as Sarah has already said, Section 10 of the RACGP guidelines addresses reprocessing of RMDs. And this section is primarily based on the requirements that are set out in ASNZ S4815, which is around office-based healthcare facilities. I will be talking a little bit about 4187 this evening, and I think it's important that we understand, I suppose, where we're coming from with changes that may well occur, because I think we're in a transition place at the moment, and that's probably what's causing a little bit of confusion. As you know, 4815 and 4187, which is the reprocessing of RMDs in health service organisations, is currently under review, and that will be superseded by the new AS 5369. Now, Standards of Australia have advised that there's no confirmed timeline for its release, but it has indicated that this may in fact be in 2023. Already there's been one stage of consultation. We're expecting a second stage before the document is actually published. So as Section 10 of the IPC guidelines is based on the existing standards, so 4815, there are no changes to practice, as we've already said, in terms of the requirements for reprocessing. And the guidelines will actually be updated after the new standard comes into effect. Now, throughout the presentation, I will refer to some shalls or must, and that is equal to being mandatory. And I'll also refer to some shoulds and their recommended practices, just so that people don't get too confused. Okay, so when AS 4815 is now 17 years old. And in the interim period, reprocessing technology, evidence-based and best practice has evolved. So we really are in a time of transition in relation to our reprocessing environment, our equipment and our processes. And I think at this point in time, we need to be open to these changes because at the end of the day, we're here for the safety and the quality of our patients, but also our staff too. So 4815, as you can see, is really around medical, dental and allied health facilities, those environments that perform skin penetration procedures, such as acupuncturists, tattooists, and also veterinary practices are required to adhere to this standard. Whereas 4187, which was developed in 2014, sets out some specific requirements and practices that are necessary for effective reprocessing, storage, handling and transportation of RMDs in human healthcare. So veterinary practices don't need to follow this standard. But what this standard does do is it applies principles, but it does recognise that there are some similarities, but there are also differences between types of health service organisations. So wherever RMDs are reprocessed, this standard applies, but it tends to apply more to larger, very significant practices, day hospitals, day surgeries, acute hospitals, the oral health, large oral health centres that might be affiliated with universities. So 4815 is really around those practices that are performing less complex procedures, particularly the use of critical RMDs, those where there's less risk of extensive blood loss and exposure to sterile tissues, and where there's a less range of reusable medical device family types. So small numbers of instruments that are focused really on, maybe 4 or 5 different procedures. So whether we comply with 4815 or 4187 will really depend on that criteria. So obviously a hospital a day surgery is doing far more complex procedures, doing far more critical procedures. They have a lot of instrumentation. There can be blood loss, even though now we have processes in place to minimise that. They are exposing sterile tissue, and they're larger type facilities. So the application of 4815 is really to smaller practices or medium-sized practices. However, if you were a very large practice and maybe you had a number of practices within your organisation and you were doing quite a lot of complex surgical procedures, then 4187 in actual fact may be more appropriate for your environment. So I work with a large oral health centre here that's attached to the University of WA. Their requirement under the standards is that they need to comply with 4187. So let's talk a little bit about the reprocessing environment. So this is the physical environment and also the equipment that's necessary in order to achieve safe and effective reprocessing. So your environment needs to incorporate the principles of environmental control so that we can minimise particulate contamination and bioburden. So we're talking about the microbial bioburden. So this is particularly important for practices where there may be in fact be new practices. So there's planning and construction going on of a new practice, or maybe within the practice there might be a major renovation undertaking in the existing reprocessing area. Or if you're an existing reprocessing facility, then you need to be making every endeavour to conform to these requirements. So we're referring to 4815 here. So as I said, the standard is a number of years old, and by now we should be able to adhere to the environmental requirements. So the standard requires that you have a designated area for reprocessing, that you take into fact some of those environmental conditions such as temperature, humidity, ventilation and airflow, and we'll talk a little bit about that soon, that there is effective segregation of clean and dirty activities. Now, currently in 4187, but also in the new draft standard, we will need to be thinking about transitioning to distinct and separate physical separation of the cleaning area from other reprocessing areas. So we just again need to be aware that there may well be changes afoot in terms of the environment. We require currently a unidirectional workflow of instruments and equipment from receipt of the instruments into the reprocessing area to final distribution. So that may in fact be going back into your treatment room and into the designated sterile storage cupboards, drawers, or containers. So we're working from dirty to clean. So in order to facilitate the function of the environment, the standard actually sets out the equipment that is required. So separate hand washing facilities, and I certainly understand that that can be a challenge for some environments. We shouldn't be using the cleaning sinks to perform hand washing. You need adequate bench space. You need surfaces that aren't porous, that are smooth and without crevices. You need good lighting. So that's under bench lighting, flush ceiling lighting, and some practices have an illuminated magnifying lamp light, because you need that to be able to inspect your instruments after they've been processed. So efficient ventilation, which is in accordance with the Australian Standard 1668.2. So that allows for the correct flow as well through your reprocessing environment. You need adequate storage for your equipment and your materials. You need waste disposal facilities. So you need to be able to store as well. Non-slip flooring, because this is an area, particularly in the dirty zone, where the surfaces can become wet. We need a suitable sink for the disposal of liquid waste. Cleaning sinks, that the recommendation is 2 cleaning sinks. However, if you only have 1 cleaning sink, then you can use a bowl as your second. And of course, we need some drying facilities as well. So there's a lot to pack in what is often a small environment. So this slide just gives you an example of the reprocessing flow in a small office space practice. So we can actually see we've got an in and an outdoor into the dirty zone, which is actually quite acceptable. Ideally, we would like to have the unilateral flow going right through from dirty into clean. There is the opportunity to separate this out physically, or a space barrier is acceptable. And we can see we've got that outdoor, which is currently optional. In our dirty zone, we can see that we have receipt of our instruments. We have our sinks. We've got 2 sinks here, our washing sink. We've got an optional ultrasonic cleaner in the middle, then followed by our rinsing sink. And then this is just a single either underbench or benchtop washer disinfector in this instance. And then we tend to have this neutral area here. So we're actually now moving from the dirty zone into the clean zone. So where we're inspecting and packaging our instruments, if that's indicated, where we have that, we're now in the clean zone. And then we move forward into our sterilizer, to our inspection and our storage area, and then out the optional door there. So you can see that we are getting that unidirectional flow from dirty to clean in this instance. But you'll also note that our ventilation system, the air should actually be going from clean to dirty. If it was going dirty to clean, then that would increase the bioburden and the risk of cross-contamination. So our ventilation requirements and our relative humidity is really important in this reprocessing area. It's not just in the consulting and the treatment rooms. But it just gives you an example of a layout of a good functioning reprocessing environment. So we'll just move on now. So when we talk about reprocessing, we have to actually determine or risk assess to what level does an item need to be reprocessed for the intended use. So the appropriate level depends on the body site in which the RMD will be used and the risk associated with the particular procedure. And then we classify that risk according to the contact site where the RMD is to be used. And this is what we refer to as the Spalding classification system. So it categorises medical equipment and devices according to their intended use, and then the subsequent level of reprocessing required to render that RMD safe for use. And so once we've done that, we can work out whether it's a non-critical device, a semi-critical device, or a critical device, and to what level do we actually reprocess that. If it's a non-critical device, is it low level or intermediate level disinfection? When we get to semi-critical, it should be high level disinfection, although high level disinfection is an automated process and it's in order to keep it safe, because we're talking about very strong disinfectants. So what we tend to do with our semi-critical devices is we jump straight to sterilisation unless they're a heat intolerant or a heat sensitive item. So all of our critical items definitely need to be sterilised And in general practice, that tends to be steam sterilisation rather than some of the newer forms of technology that have come on the market and are probably quite difficult to manage in an office-based practice. So reprocessing really begins with processing at the point of use. So in other words, close proximity to the point of use where the device actually facilitates the subsequent cleaning steps. And that's what we will be working through today. So this slide just shows you the level of risk in relation to critical, semi-critical and non-critical devices, and then the level to which we need to reprocess that item. So we can see with our non-critical items, such as our stethoscopes, our BP cuffs, our pulse oximeters, that they need to be cleaned after every individual use on a patient with detergent, with a neutral detergent, or perhaps a neutral detergent followed by a low or an intermediate disinfectant, or combined with a low or intermediate disinfectant. Then as we step up the level of asepsis to a semi-critical item that comes into contact with intact, non-sterile mucosa or non-intact skin, then cleaning is important as soon as that device has been used. And then we move into the sterilisation process or high-level disinfection. But as I said, this tends to be an automated process that's not readily used in the office-based practice environment. Or alternatively, we can use single-use devices. And I've given some examples of those devices that come into contact with non-sterile mucosa or non-intact skin. And again, the highest level of asepsis is our critical items. So these enter or penetrate into sterile tissue, cavity, or bloodstream. They need to be sterile at the point of use. So they must go through a cleaning process and then they go through a sterilisation process. Now, as I said, commonly in office-based practice, we use steam, but there are some low temperature chemical sterilisation processes on the market, but we tend to see them used more widely in hospitals and day surgeries. And of course, we can look at our single-use items. And again, I've given some examples there. The important thing, though, with our critical items is that we have to maintain their sterility right up until the point of use. So that means that they require packaging. This just add-on slide's a little bit difficult to see, but really this is, I suppose, just demonstrating the different levels of reprocessing. And we need to be considering the organisms that we are actually trying to kill. So we can see with our low-level disinfection of our non-critical items, where we can actually remove or inactivate or kill the majority of microorganisms. However, when we're looking at mycobacteria, fungi, and our non-envelope viruses such as rotavirus, norovirus, they're a little bit more difficult to kill. And we may need to use an intermediate level disinfectant if the low level disinfectant that we're using, the manufacturer's instructions indicate that it's not effective against those specific organisms. And as we move up, we can see that the sterilisation process is actually designed to kill all microorganisms, including spores. In terms of single-use medical devices, and we've had a couple of questions coming through on the advisory line, single-use medical devices really should be used based on the clinical situation. And these are items that are used only once and they're discarded correctly. So we tend to use single-use devices that if they're very small and or they're sharp or they're difficult to clean. You know, we talk about dental burrs in the dental world, and a lot of dental burrs used to be reused and reprocessed, but more and more now, because they're so difficult to clean, we've moved towards single-use, sterile. So if an item is single-use, labelled single-use, and it'll be written in wording as single-use, or it will have the symbol that you can see on the top of the screen there. These items cannot be reused. So if you have instruments that are colour-coded with the blue, look a little bit closer because you'll find that they're single-use. You cannot reprocess these in your office-based practices unless you are licensed by the TGA and that all of your reprocessing actually complies with the rigorous manufacturing requirements that are demanded by the standards. And I don't know of any office-based practice that has would probably come close to actually meeting the TGA requirements for this. The RACGP guidelines make quite a clear statement about whether you're choosing to reprocess or to use disposables. And they say that single-use disposable alternatives are now available for most categories of medical devices that were traditionally reprocessed. So your policy on whether to use disposables or reusable medical devices needs to be determined based on a thorough analysis of the factors, including the risk of contamination and the costs associated. And the section 10 of the guidelines, actually we've included just a simple cost benefit analysis framework so that you can actually undertake that analysis to determine whether single-use disposable may in fact be better for you than reprocessing reusable medical devices. And there's lots that you have to consider about, you know, staff time, number of instruments that you require, the equipment that you have to purchase, replace, the validation, the performance testing, etc. So you really need to weigh up what it is that you're doing. So there are actually options in terms of reuse medical devices. So one of the options is to outsource to an off-site provider. My suggestion would be that if you are doing that or you're considering doing that, that you ensure that they're a licensed facility and or they're an accredited facility so that they've been through a rigorous process and that they do meet the relevant standard. You certainly need a service level agreement and I would strongly recommend key performance indicators are included in that SLA and that should include things like compliance with the relevant standard. So in this case, 4815, or when the new standard is published, then we would need to include that. You also, if you're going to have a off-site provider, you need to really establish what your pre-treatment, what your cleaning, collection and transport processes will be, because we still have to be responsible from the point of use right through to the distribution back to you of reprocessed items. If you don't choose a single-use option, you don't choose to outsource to an off-site provider, and you choose to do your on-site processing, then this should only occur if the practice can conform to the requirements of the current relevant standard. So let's step through some of the key processes. Now, in the interest of time, we're not going to be able to go through this in significant detail, but that might be an opportunity for questions later or through the helpline. So this slide is really just showing you what the RMD process pathway is if you are selecting to reprocess your devices on site. And we can see up the top of the slide that we use our RMD on the patient at the point of use. There is a process of transporting that safely through to an area where we may need to hold. We might need to initially, if we haven't pre-treated at the treatment side, and we've got appropriate timing, we can come through and rinse or pre-treat actually in the reprocessing area. We then go through process of cleaning our instruments, whether that's mechanical cleaning, which is accepted under the standard currently, or whether that's some form of mechanical cleaning through an ultrasonic cleaner or through an automated washer disinfector. We then rinse and dry, package, sterilize our instruments if they're semi-critical or critical, and then they go into storage ready to be used on the next patient. So I've put a few definitions, just a couple of slides so that we all understand where we're coming from. So there's sometimes a bit of confusion between the terms pre-cleaning, initial cleaning or initial treatment, but I suppose the official definition is pre-treatment, and this is when we're removing any gross soil at the point of use wherever possible. Cleaning is the removal of soil and the reduction in the bioburden or the number of microorganisms on the surface, and that is always the first step in reprocessing and the most important step, because if we do not clean our RMDs effectively, then the next step, whether that's disinfection or sterilisation, is not going to be effective. Disinfection, as I said earlier, the next level up is about inactivating our non-sporing organisms using either heat and water, so we refer to that as thermal disinfection in an automated process, or if it's heat sensitive or heat intolerant, by chemical means. But this really only refers, I think, in office-based practice to our non-critical items. And again, the next level up is sterilisation. So it's a validated process that we use to render any RMD free of all forms of viable microorganisms, including spores. So pre or initial treatment is really important. We're aiming to remove any gross residual soil as soon as possible at the point of use. So that can be done through dry wiping, damp wiping, or if you are able to move those used RMDs straight through into your reprocessing area, you can rinse them in the dirty sink. Remembering that cold water will congeal fatty substances, while hot water will actually coagulate protein in blood and body fluids and make it much harder to clean the item. Now, interestingly, in 4815, it doesn't state it at the moment, but in the current 4187, but also in the new draft standard, it refers to having policies where you actually specify the maximum period of time permitted to elapse between the use of the RMD and subsequent processing. So the idea at this stage is to ensure that you don't cause any damage to the RMD, that you don't compromise subsequent cleaning, disinfecting and sterilising processes, and that you minimise the risk of the soil drying on the instruments. Now, there are pre-treatment products that are available on the market. If there is any delay in the subsequent processing, and that's particularly useful if you're looking at off-site processing or transporting items from one place to another where you might have a central reprocessing area, and so particularly important, particularly valuable if you're going into residential aged care facilities, doing home care visits, or as I said, your central reprocessing area is actually away from your primary practice. So collection and transportation. So this process should not cause damage to the RMDs, and it shouldn't again compromise any subsequent cleaning, disinfecting or sterilisation processes. And again, it needs to minimise that risk of drying instruments. So we need to be able to transfer our instruments through to the reprocessing area in a safe way as well. So a cleanable, puncture and leak resistant container with a lid or an inner liner that can be closed. And remembering you can colour code this, you can label it, so it's very clear that there's a difference between the container that contains dirty instruments to the container that contains clean and sterile packaged instruments. Keep it very separate. So there's not, and this is particularly important if you are transporting to another site for reprocessing, or you are sending your RMDs off to an external service provider. In relation to our cleaning methods, the cleaning process must be compatible with the RMD. So we're now starting to transition to a process that when we purchase our reusable medical devices, we ensure that we've got the manufacturer's instructions, and they will provide validated instructions on how you reprocess that item. So you do that in accordance with those instructions, and in particular the cleaning instructions. If you're unable to safely and effectively meet those cleaning requirements, then you shouldn't be reprocessing within the practice, and the standard's pretty clear on that. 4815 also says that the use of mechanical methods may be contraindicated. So this is why, you know, it's best practice using an automated mechanical process for cleaning. In some situations, for very delicate or complex instruments, it would be contraindicated. And in those instances, then careful hand washing or using single-use devices is certainly recommended. But at the moment, under 4815, the manual cleaning process is currently acceptable. But it is really important that you have thorough rinsing if you are manually cleaning these items, so that you remove any detergent residue. If you leave residue on an instrument, and you subject that to the sterilisation process, it can compromise that process. So mechanical or manual drying with a lint-free or a disposable low linting cloth prior to inspection is all part of that cleaning process. And remembering that if we don't dry, that can actually increase the risk of contamination during inspection and assembly if you do need to assemble your devices. Any residual moisture may impede the sterilisation process, and it can damage instruments as well, and instruments are costly. So in terms of our cleaning methods, manual cleaning of an RMD. Now, and I'm putting this in just so that we're aware that we are transitioning and that we're conscious that 4815 is a very dated standard. So 4187, which was developed in 2014, and then the draft of the new standard currently says that manual cleaning of an RMD shall only be used where the RMD manufacturer's validated cleaning instructions say that the instrument needs to be cleaned using a manual process and as a pre-treatment prior to reprocessing in a washer disinfector. So I think this is where some of the confusion is starting to come into play, that we have an existing standard that says, yes, we can manually clean, but we also are moving, because of technology and best practice and evidence-based practice, we're moving to a more validated process. It's really difficult to validate manual cleaning because we all do it a little bit differently. So an automated process, such as a washer disinfector, is actually preferred. And it has lots of advantages. So these are closed cabinets. They're linked to the water supply and to the drainage system. And they include a pre-rinse with water, a wash in warm water with a cleaning agent added. Then they have one or more rinses with hot water. So this achieves that thermal disinfection of between 80 and 86 degrees Celsius. And it has a drying agent added to it as well. Then we have the draining. So that actually leaves the contents at a temperature for quick drying. And then we have our drying process. So it's effective, it's efficient. It certainly decreases your risk of exposure to blood and body fluids and sharps. It keeps the instruments in good condition. It's far more reproducible than manual cleaning, and it is a validated process. However, under the current standard, the ultrasonic cleaning process is acceptable. And ultrasonic cleaning tends to be used for jointed and serrated stainless steel instruments. So when we consider ultrasonic, using ultrasonics, we have to also be aware of the limitations, and there are quite a lot of limitations associated with ultrasonic cleaning. Now, we know that this process actually subjects your instruments to high frequency, high energy sound waves, and that causes the soil to actually be dislodged or sufficiently loosened so that when you undergo that thorough rinsing process, it enables the removal of the soiling. So we can see that there are lots of things that we can't put into an ultrasonic cleaner. It does tend to, because of the mechanical shaking that occurs, it does tend to blunt fine points. If you can't put cannulated instruments into what I refer to as an ultrasonic bath, unless it is an ultrasonic washer that is specifically designed with connections that can be added to your cannulated instruments. Before you put items into an ultrasonic cleaner, you need to remove that gross soiling, so it needs to be rinsed prior to immersing into the tank. And then when you remove those instruments, you must thoroughly rinse them in clean running warm to hot water, and then visually inspect them to make sure that they are in fact clean. So when I talk about ultrasonics, I often talk about ultrasonic baths versus ultrasonic cleaners. Now, an ultrasonic bath is really not a full cleaning process, because if you think about it, you put your instruments into the basket, you switch it on, you remove them, you rinse them, then you put the next load of instruments into that bath, and it's a bit like a family that has, a group of children, and the first person who gets in the bath actually gets washed and comes out clean, but the subsequent kids that get in the bath, in actual fact, are being cleaned in dirty water as such. And an ultrasonic bath is very similar to that. So it's not a full cleaning process where we empty it out after each use. We clean the ultrasonic, and we refill it and degas it, and then for the next lot of instruments that are going in. So this is really why 4187 currently and the new draft standard actually states that if you're using an ultrasonic cleaner, then further manual cleaning or a mechanical cleaning process such as a washer disinfector is actually required. So ultrasonic in those terms, in those standards, is actually seen as a pre-cleaning. Okay. And I've just popped that little picture up there in the vain hope that your ultrasonic cleaner, when you place your instruments into the the basket, that's what they will look like. It will be a single layer of instruments, not a whole load of instruments jammed in on top of one another, because that won't actually produce good cleaning of those instruments, which is what we want. So our packaging is also a really important part of the process. So we need to be using validated packaging materials and materials that actually will permit the removal of air from the pack, allow for the penetration of the steam into the pack, and then the removal of the sterilising agent and any water vapour that might be left behind. So it's really important with your packaging, whether you're using self-seal pouches or laminated roll or you're wrapping, that you check for any damage. You check the expiry date prior to use as well. So don't decant your self-seal pouches, for example, from the box that they come in, because often it's the box that actually has the expiry date on. Make sure that you choose the correct size. So whether it's a laminated roll or it's a pouch, you want to be able to contain all the contents. Only fill the pouches to 3/4 of the overall space. Make sure you leave adequate space at the end so that you can actually open the packaging in an aseptic manner. Remember that any hinged or ratcheted items need to remain open and unlocked. Any multi-part instruments need to be disassembled or certainly loosened. If you have sharp pointed items, they should be protected by using validated tip protectors, following the manufacturer's instructions. Any bowls, hollowware that you use, the openings are always against the non-laminate surface, for example, the paper, and that's so that we can actually allow for the water vapour to be removed during the sterilisation process. And always remember that your packaging needs to be established during your validation of your steriliser on commissioning or recommissioning if that was required, and annually thereafter. So if you change your packaging, say you went from self-seal pouches to rolls and indicator tape, or laminated rolls and a heat sealer, you would need to have your service provider perform validation on that, because you've now changed the process. So that's really important. So tracking or tracing. Now, tracing refers to the ability to track a single instrument through each cycle of use on a patient, and then subsequent reprocessing through the sterilisation cycle. Whereas tracking actually links the steriliser cycle batch information of a critical item or sets of items that have been sterilised with a critical procedure performed on an individual patient. So in office-based practice, we tend to do tracking. Tracing actually can be quite difficult, and you're tracing every single instrument, and it usually requires instruments to be etched using a barcoding system to be able to track and to trace every instrument that's used on that particular patient. So we tend to do this batch cycle tracking instead. And there are 3 different systems. There's the old traditional pen and paper. There's the batch labelling gum, which I know many practices use. And more recently, with the changes to technology, we have the electric barcode or radio frequency identification system. All of them have advantages and disadvantages. I think the thing about 4815 at the moment is that because it's dated, it's actually not kept up with some of this technology, and it tends to refer to the traditional pen and paper or the batch labelling gun systems. But it is important that we can identify and track each critical reusable medical device. Semi-critical devices aren't required to be identified and tracked. However, it is good practice to do that. And certainly it would be reassuring for those of you who are using reusable vaginal spectrums, as the patient, I would like to know that that's being identified and tracked in the event that there was a sterilisation process failure. So each critical item or a tray needs to have batch control identification, and we need to be able to link the steriliser cycle batch information to the patient. And 4815 clearly states that that needs to include the steriliser number or code, depending on how many sterilisers you have in your practice, the date the item was sterilised, the cycle or the load number, and also the operator ID, really critical. And that's about accountability and responsibility. And in the end, in the event that things go pear-shaped, that we can come back and really do a root cause analysis and talk to the people who've reprocessed to identify, was there anything that you noticed that wasn't right or that went wrong in the cycle. So pre-sterilisation batch control identification should actually be done after the steriliser and cycle assignment, but before you actually put the steriliser on. So that's what's in the current 4815. But as we know, for those of you who use a barcode system, for example, that you actually produce and attach that after the cycle is completed. So there's a little bit of a gap there in terms of the requirements. For those of you who are using any sort of implant, usually this is purchased as a commercially prepared, it's sterile. You must record the batch lot or the batch or the lot number in the patient's record. So again, that can be tracked in the event that there was a requirement for that. So at minimum, the tracking or the traceability system shall be sufficient to enable the identification of a patient where a non-conforming item has been used in an event that a recall is necessary. So it's really important that we have a recall policy as well, so that if it goes pear-shaped, you have a process that you can follow, and you can go right back and look at all of those critical points in the process to identify, was there a deficit, did something go wrong? When these sorts of things happen, it's usually not just one single issue, it's usually a number of factors that come together on the day that leads to the failure. And it's not necessarily the sterilisation failure, it can be any part of the process, the cleaning, the packaging, and the storage as well. So in terms of our sterilisation records, under the standard, we need to have a record for each cycle, the date of the cycle, the steriliser number, the cycle or the load number. We have to be recording the physical parameters. So that's the exposure time, the temperature and the pressure, the name of the person who's authorising the release of the load content. So this is a really critical role. We need to identify the specific contents of the load. And also the readout, as I said, of those physical parameters, but in addition, any chemical indicators or biological indicators that you may be using. So the standard requires us to document all the contents of the sterilisation cycle. Now, whether you do that in a logbook that you have developed yourself, or whether you use the steriliser logbook, if you've got all of those records, you can identify any failed cycles on the log sheet and reprocess that load. It is important to remember that the standard says that in the event that you move your steriliser or you replace it, the logbook or the log sheets need to remain where the sterilising has been undertaken. It doesn't disappear with the steriliser. And that's because we need to be able to have that tracking system in the event of a recall is required. So having that documented recall procedure and policy is very important. Now, your sterilisers, it's critical to know what type of sterilizer that you have and that you're using the appropriate sterilizer for the RMDs that you are reprocessing. So when we purchase sterilizers, or in fact any reprocessing equipment, whether it's a washer disinfector, an ultrasonic, whether it's a heat sealer, whether it's your biological indicator machine, then you need to make sure that it meets the existing Australian and New Zealand standards and that it has been TGA approved. So N-class sterilisers are only suitable for unwrapped solid items. So we don't tend to see these types of sterilisers. They've more or less become defunct. The Class B sterilisers are all encompassing. They can be used for all wrapped, single or double, or unwrapped items, and that includes porous and cannulated items that don't exceed the specifications of a hollow A type load. But I would say that most practices are probably using an S-class steriliser. And so these items are actually capable of sterilising unwrapped solid items and at least one of the following. So if you have an S-class, it's really important to know what cycle it can. Can it sterilise porous items, hollow load type A, hollow load type B, single layer wrapped items, or double wrapped items? So whatever you are reprocessing, you need to ensure that the steriliser is capable of sterilising that load. Really, really, really important. Loading is another part of the process. So if we don't load correctly, then the sterilisation process may not be effective on that particular item. So we never place any RMDs ready for sterilisation into the steriliser until we have a complete load. And really what that is about doing is trying to avoid any errors, any contamination of the packaging by residual moisture that may still be in the machine from the previous cycle. We don't want to increase the microorganisms. We also don't want the deterioration of the chemical, the external chemical indicators or the internal chemical indicators, because the sterilizer may be quite warm. If you hold a chemical indicator over, a kettle or expose it to the sun, it will change color. It doesn't mean that that's been through a sterilisation process. So the load types and the packaging need to be the same as those that your external service provider has validated during your yearly performance requalification. If you change the loads, and as I said before, if you change your packaging, you need to go through that validation process. You need to be assured that those items and that packaging is being reprocessed to the correct level. So I've just put a few little tips about light items that are placed on top shelves, and heavy items tend to go on the lower shelves, and that packs or pouches or other items are loaded well within the boundaries of the steriliser tray or the racks. So please refer to your steriliser manufacturer's instructions, because they will provide you some guidance or some rules around how best to load your particular steriliser. Certainly if you're using hollowware, we like to have it placed on an angle, and that actually allows the condensation or any water vapour to drain, but it also allows for that air removal and the steam penetration. If you're using single laminated pouches, they can be placed vertically in a spacer, but it must be laminate to paper. Your loading trays, if you're loading horizontally, then it should be just a single layer of packs. They shouldn't be overlaying one another. In terms of the laminated pouches, the standard, which as I said is very old, actually states that those pouches that are placed horizontally need to be placed with the paper facing downward. But it does depend on the type of sterilizer that you have, because some of the brands, or one of the brands in particular, actually in the manufacturer's instruction says that the paper facing must be upward, but certainly not overlapping. So again, always go back to your equipment manufacturer's instructions. Releasing and unloading a sterilised load. So before you touch the sterilizer, before you open the door, hand hygiene must be performed. So we need clean hands to open that sterilizer door, and before we handle the packaging. We don't want to compromise it unnecessarily in any way. We don't interrupt the cycle or open the door unnecessarily until the sterilizer has completed its entire cycle and the pressure has returned to zero. I think that's the important thing about sterilizers, is they're a pressurized vessel, and you have to have your certificate in relation to that. So they're not a safe item necessarily, because they are pressurized. So sterilizers these days, you can't open the door or crack the door unless you've got a very old one. But before you open that sterilizer, remove and check the sterilizer process printout. So if you have a record, or look at the digital display to confirm that the sterilization parameters have been met. So you really need to be familiar with what those parameters are, what the temperature, time and pressure is for the cycle that you have put those items on. If you have a printout, sign or initial that printout and have a log of names and signatures or initials so that it's easily identifiable. So what you're doing when you sign off, you're being accountable that the items have met all of the sterilization parameters. Make sure that when you pull out that tray, that you're looking at the pouches. If you use a control pouch, you're looking at the indicators, the external chemical indicator, to make sure that that has changed. Doesn't mean the item is sterilized. All it means it's been subject to a sterilization process. So different indicators have different color changes. So again, you need to look at the manufacturer's instructions to determine what is the initial color and what is the expected color change following the sterilization. Always open the sterilizer carefully and carefully remove the load. Again, we don't want to compromise that sterility process. So when we release the load, we're checking the class 1 external chemical indicator for a clear, even color change. And ideally, you should record that result. Check that the packs or the items are not wet if they're critical, that the wrapping, the packaging is intact, that if it's flexible packaging like the self-seal pouches, that again, the seal is intact and it's secure. Check that the batch item information corresponds with the documentation, so what you've recorded. That's really important. Make sure that if you are using a batch label that you're applying to the package, that it hasn't dislodged during the sterilization process. And any other sort of indicators that you use, record that on the sterilizer cycle record. It's all about, if in the event, as I said, if it goes pear-shaped, we can go back and we can look at every part of the process and be confident that we've met the requirements. If you use biological indicators, then obviously record those on the sterilizer record as well, and record the name of the person who released and unloaded that load. So there are a number of sterilizing process issues that can actually occur, and I'm hoping your sterilizer up on the top right-hand slide of the slide never ever looks like this. So some of the common errors that can occur is that initial improper instrument cleaning, and you can finish up with bioburden and other debris on the instruments, and that will then actually impair the sterilization process. And in actual fact, you may finish up that the microorganisms become even more adherent to the surface of that device. Improper packaging, using the wrong type of material for the method of sterilization, too many items in the package, not sealing it correctly, double bagging, double wrapping, using too much indicator tape. Really important, the standard outlines, how to package items correctly. Overloading the sterilizer, as we can say in this picture, there's no way that we're going to get good steam contact with all surfaces of the instrument if a sterilizer is overloaded. Also maintenance, sterilizers, as I said, they're pressure vessels. When they work, they do a fabulous job, but they do need maintenance. The seals wear, the gaskets wear. So these are all part of the checking procedures, the documented procedures. and they should be in accordance with the maintenance requirements that are set out in your steriliser manufacturer's instructions for use. And as I referred to earlier, making sure that you do have appropriate sterilisation equipment. In fact, all of your reprocessing equipment needs to be TGA approved. Cooling, you need a dedicated area away from high activity within your reprocessing area so the items can cool, and they should come to a complete cool. So that can be a minimum of 30 minutes, and with some items that can be as long as 2 hours or even longer. But I think for the purpose of office-based practice, we do tend to use small sets of instruments, individual instruments, so they will dry quicker. But they need to be dried and cooled prior to transferring to your storage area. So don't ever place items when you bring them out of the steriliser, don't ever place them straight down onto a solid surface. You need to put them onto like a cake rack or some sort of surface where we can get good ventilation, good air circulating around, and that will minimise that effect of sweating. Because if we have sweating, it means we have moist packaging, and we can't use instruments that are in moist packaging. And remember, don't ever try to force cool items. Sometimes I've seen little portable fans, or I've seen items being placed under the air conditioners with the vents turned down so that to try and speed up the cooling process. It compromises the sterility of items, and you get air turbulence. So it has the ability to actually move microorganisms around, particularly, from dirty to clean. And we've already talked about not doing that. Sterile stock storage, a very important part again of the process. So ideally you want to store your reprocessed items behind closed cupboards, drawers, or lidded containers, preferably not out on open shelving, especially if you have a reprocessing area that's quite small. So the temperature range in accordance with the standard for sterile items is between 18 and 25 degrees Celsius, with a relative humidity of between 35 and 70%. Very easy to put a hygrometer into where you store your sterile items just to see what the temperature is. I always recommend to do that so that you've got some idea that you're within the range. Items should always be not stored in a thoroughfare or in a working area, because again, we're trying to minimise the movement of airborne contamination. We segregate sterile goods from non-sterile goods. Now, this can be a physical segregation, or it can be an adequate space segregation. Keep items away from direct sunlight. If you are using open shelving, just look at the height requirements from the floor and also from ceiling fixtures. However you store, whether it's in cupboards, drawers, shelving, or containers, make sure that it's non-porous, it's smooth, and it's easily cleaned in accordance with your documented cleaning schedule. And we talked about the lighting. Overhead lighting should always be fitted flush, because that will actually minimise any sort of dust entrapment. You should have a stock rotation system, and that system should be standardised, and that all staff should know what that is. So we're trying to ensure that the oldest manufacturer date is at the front or the top, so that it's used first. You can use the principle of taking from the left and replacing to the right, or if you store in containers, you might take from the front and replace to the back. But have a system in place and ensure that everybody understands what that system is, depending on whether you're using cupboards, drawers, containers. As I said, keep your storage containers clean, dry, and in good condition. We don't like to use cardboard boxes, particularly corrugated cardboard boxes, as storage containers, because they're porous and you can't clean them. Don't overstock, cram, or squash your sterilised stock into containers, drawers, or your shelves, because again, this can compromise the sterile integrity of the items. So we really want to make sure that we have good, safe storage. Also, sometimes the questions that we get are around the safe storage times for sterile packs, and that can vary depending on the porosity of the wrapper and the storage conditions. So open versus closed containers, for example, or cabinets. So heat sealed, plastic peeled down pouches have been reported to remain sterile for as long as 9 months after sterilisation. But really what you need to ensure is that you have a process in place. Ideally, you know, if we've got items that are very rarely used, well, I suppose we have to question why are they in the practice. But if they are an item where the procedure may only be done, you know, once or twice a year, have a process in place in terms of reviewing that packaging, checking the expiry dates of the packaging, and maybe you will have to actually reprocess them and repackage them, because sometimes with the laminate, it can go brittle and it can discolor. And that's the important thing about when we go to use our sterile items, that we check the packaging at the point of use to make sure that it's still meeting the sterile integrity requirements of it. So these items tend to be more event related. So if you have a factor that compromises your sterile stored items, then that would be seen as a failure or a non-conformance, and you would need to reprocess that. Okay, and moving right along, performance testing, monitoring, maintenance and validations. I'm not going to go into significant detail. This is a whole topic on its own. The RACGP IPC guidelines cover this really well. But suffice to say that, you know, your sterilizer, in fact, all of your equipment, but for most of you, it's probably the sterilizer that is the automated process in your reprocessing area, is the sterilizer needs to undergo performance testing, and that will depend on the type of sterilizer. If you're also, and you need to refer again to the manufacturer's instructions, whether it needs a leak rate or a vacuum test. And this is really testing that if you have a sterilizer that uses a vacuum stage for air removal, that is actually working. It's always undertaken on an empty chamber, and it's undertaken prior to doing a Bowie-Dick type test or a PCD if you had a B-class sterilizer. If you don't have a B-class sterilizer, then that second performance test is not required. So again, refer to the sterilizer's manufacturer's instructions to determine whether you need to do this test on a chamber that is warm or cold. Also, how frequently you need to do that will depend on whether you have an air detector in your steam sterilizer or not. And also, this test is always carried out at installation on operational qualification and performance qualification by your service provider. The air removal or the steam penetration test, which is our class 2 chemical indicator, often referred to as a Bowie-Dick or a process challenge device or helix test. This again is a mandatory daily test, but it's only for B-class sterilizers and more modern S-class sterilizers that process hollow A loads. If you don't use hollow A loads, then you won't need to do this test. So it's always performed before the loads are processed each day and after that initial vacuum or leak rate test. So with every load, we need to be monitoring. So we look at the printout or its direct observation of the display, and what we're doing is we're looking at the recording of those cycle parameters, so temperature, pressure, and time. You look at the class 1 chemical indicator, which should be on every package, so it's external, or if you have an unwrapped tray, you should have a class 1 chemical indicator sitting on that. Now, the standard does say that doing any other sort of chemical indicator inside the pack, so 1, 4, 5, or 6, is optional. Some people like to do it because it's an extra, I suppose, evaluation of the process. Your biological indicators are required at operational qualification and performance qualification, on recommissioning and performance requalification, if that is indicated, if you've had a problem with your sterilizer. But again, you're talking with your service provider in relation to this. Some practices like to do a regular biological indicator. They don't like to wait for once a year when their validation is actually undertaken. And a process challenge device in a class B sterilizer is still optional at this point in time. And what a process challenge device is for those hollow items, it actually measures that the steam was able to penetrate the most inner part of that hollow item, which is really important if you're using hollow items. This next slide just gives you an example of the different classes of indicators and what they're used for. So I'll leave that for you to be able to go through later, but we do know that a class 1 is mandatory. The class 2 is mandatory and a B class, but the others are actually optional. And it just depends how many parameters you want to look at as to what class indicator you use. Maintenance is critical. And this is not just maintenance of your sterilizer. If you have an ultrasonic cleaner, it may require maintenance depending on what type of cleaner it is. A washer disinfector needs regular maintenance. Some practices have a drying cabinet, so rather than manual drying with lint-free cloths, they have a machine that does it. If you use a heat sealer for sealing your laminate roll, your sterilizer, if you have a biological incubator or reader for your biological indicator measurements, all of these need routine checking, cleaning, calibration if they're a measurement device, and maintenance. So having that maintenance schedule is critical. So again, you refer firstly to the manufacturer's instructions, what they require, and you also look at 4815. And your preventative maintenance should be undertaken by a qualified service provider that is actually accredited to work on their machine that you have. So we know ultrasonic cleaners need their daily performance transducer test. They need their annual electrical safety check, your washer disinfectors. We need to be able to have documented time and temperature for every cycle. They require a daily test for chemical residue, and again, an annual electrical safety check and other maintenance by your service provider. So ensure that all of your equipment is accounted for within your practice. And coming towards the end is around our calibration and validation. So a critical part, we need to know that our equipment is working. So, you know, our washer disinfectors require validation and our sterilizers require validation. And validation consists of commissioning. So at the time of acquiring the sterilizer and also when performance qualification is actually performed. And what it's actually doing is it's evaluating the reliability of the reprocessing process. Okay, so whether that's washer disinfector or whether it's your sterilizer. And Appendix F in NZS 4815 actually describes the validation process for steam sterilizers really well, as do the IPC, RACGP IPC guidelines. So validation is actually repeated annually. So after your machine is initially commissioned, and also every time there is any significant change made to the parameters. So when we're talking about time, temperature, pressure, but also any changes to any packaging or loading specification, which provides us the greatest challenge to that process. So if there are any changes in the items or the types of instruments that you reprocess, so you might introduce a new surgical procedure into the practice that requires you to use different instruments, then and if that creates a greater challenge to your previous validated items, it needs to undergo validation. So installation qualification is providing assurance that the equipment and its connected services, so the water and the drainage, comply with a specific set of specifications, and it's safe and it's fit to use. Your operational qualification provides you with assurance that the equipment actually functions correctly to a set of performance criteria. And then your performance qualification is actually demonstrating that your equipment is capable of processing the load. So it can actually achieve those minimum conditions through a specified load. So it achieves that minimum sterility assurance to a level of 10 to the power of -6. So your service provider will provide you with a performance qualification report and also a validation test report. So it's and a single page report doesn't meet the requirements. So if you have If you have a service provider that's providing you with a one-page report, you need to really question that. Unfortunately, there's still some cowboys out there, so we need to ensure that our service providers are meeting the requirements of the standard. So never ever assume that the equipment that you're using to reprocess is actually achieving the process without that process being validated. Very, very important. And I understand that validation is expensive, but it's a very important part of the process. And just coming towards the end, we all know how important documentation is. So we require policies and procedures for all of the reprocessing activities that you undertake. So from that pre-treatment at the point of use, right through to your storage and then transport back to patient side for use. Ensure that you have good version control with your documentation as well. You need to maintain your records and you need to be reviewing them at regular interviews to identify any gaps or any improvements that could be made. So all of your equipment tests that are performed, your sterilizer cycle records, any equipment cycle records, your employee training records, incident reports, so if there's been a non-conformance such as a sterilisation failure, your recall reports, any quality and your procedure operational manuals, and that includes the equipment manuals as well, any maintenance records, your validation certificates for IQ, OQ and PQ, and of course your tracking records. So these need to be maintained for a minimum period of time, and you need to look at not only your practice policy for retaining records, but also what is defined in the regulatory authorities, and they do differ from state to state. And to finish with our education, training and competency. So 4815 does state that a person in charge of providing reprocessed items should have adequate knowledge and skills in the reprocessing procedures undertaken. So there needs to be staff qualifications and staff levels that are sufficient to ensure that you have continuous, safe and an efficient operation of the reprocessing area. So it really does require the person who's managing to have appropriate knowledge and skills and competency in reprocessing. And that gets developed over time. The standard requires that there's a formal orientation program and that's followed by on-the-job training of all of the relevant processes involved in reprocessing in your practice, and that there should be a system for assessing staff performance after orientation and at regular intervals, which is determined by the practice. So currently 4187, but also the proposed new standard has very similar requirements around education, training and competency. And 4815 actually outlines what needs to be included in that orientation program as well. Okay, so in a whirlwind tour of reprocessing, I've come to the end. So what I'll do is I shall just stop sharing my screen and hand you back.
Thank you, and I will share my screen. Alrighty, so amazing, thank you. Oops, have I just frozen?
Screen's disappeared.
Has it? Hopefully it'll come on in a minute. I look like I've frozen from my side, so if you can hear me, we'll go with that. Thank you so much for that, Megan. That was absolutely amazing. And there's been a couple of questions around, will the recording be made available? Yes, it will. We know it's a lot of information to take in. It probably feels extremely overwhelming, but I just want to reinforce again, nothing's actually changed at this point in time. And so, you know, it's more around going back and having a look at your processes and actually deciding whether or not you have been meeting the standards. And if not, what do you need to do from that continuous quality improvement? Now, I am aware we've got 6 minutes left, but we have had quite a few questions come in whilst you've been talking. We are happy to stay on for probably a few, 5 or so minutes more if people are wanting to stay, and we'll attack as many of these as we can. We will also be sharing responses in regards to the answers to a lot of these questions in your resources afterwards. So I'm going to hit the ground running here with you, Megan. I'm going to start at the top, and that is, I need a recommendation for a tracking system. Query barcode scanning. Also, if it can do stock control, that would be a gastric bonus. Small GP, I think that's meant to be, yes, a huge bonus. It's a small GP clinic. Now, you spoke very much around tracking and tracing. Any thoughts on that?
Yeah, I think if you're a small GP practice, you want something that's simple and practical that meets the standard. And there are different costs associated with different systems. So you really, I can't recommend any particular tracking systems, other than to say that there are a number on the market. It might be helpful to talk to your service provider or your consumables provider to look at the different systems and look at, are they going to be practical? Are they appropriate for your practice, for the level of reprocessing that you do, the number of instruments that you use? Can all staff who reprocess use the system? And also, the cost effectiveness of it. A lot of people, stay with the batch control system, the identification system, a piggyback system with a gun, because it's simple. Barcoding takes, I suppose, can be more time effective because you're scanning and you're loading directly into your computer system, and then you can keep that record for significantly longer periods of time without deterioration. But my recommendation would be, go out there onto the market and look what's available, talk to your suppliers, and get an understanding of what each system can do and how well that's going to fit with your practice.
Fantastic advice, thank you. And the next question I will just put out there is difficult to answer, because very similar, it comes down to your individual office-based practice. But Jenny's asking, what are the costs of single use versus reprocessing simple equipment? Do you want to maybe pass comment on that?
Yeah, it is a little bit difficult. I probably would refer you to the template in the RACGB guidelines, because it's a very simple template, but it just gives you an opportunity to write down the simple instruments that you are using, and then you can look at what is the cost of purchasing in that, whether it's a disposable scalpel handle or disposable suture set, and then actually look at what the true cost to actually reprocessing that item, taking into account staff time, all of those things I said right at the beginning, the maintenance, the consumables, even down to your water and your electricity. And you might find that for a small practice doing very simple procedures, that it's actually more cost effective to go to single use. That's been my experience working with podiatrists in particular, who are doing fairly simple podiatry, those that might be doing home visits, that type of thing. They've actually found that when they've done the cost analysis for them, it's been more cost effective to go to single use disposable.
And we're certainly finding the clinics that we are doing the audits on, certainly, in fact, I think probably 90% of them have now gone to single use items, and they have a large number of items that they're using, and when they did their cost analysis, it was certainly better for them. So like Megan says, go and have a look at the template that's in the guidelines, and I think you'll be surprised at the outcome of that. The next one is from Carolyn. Carolyn's asking, hinged instruments, do they need to be fully open or partially open, unclamped when packing?
They should be partially opened, but you really having them fully open, because sometimes these items are sharp as well, and that could actually cause a hazard. But as long as they're open to the point where where they're hinged or they're ratcheted, the steam will actually be able to penetrate and then to be able to be drained off.
What is the day of us having them all the way open? And then
Sorry?
I said, gone is the day of us having them all
Yeah.
the way open and slid into the package, which of course can then pierce the packaging, etc.
Exactly.
Yeah, fantastic. Belinda's asked, is there a minimum time between instruments being dirty to when they can be when they're being cleaned?
That depends a little bit. There's no prescriptive time. Again, it will depend on the instruments that you're using, how complex they are, the procedures, how soiled they become. If you're doing that pre-treatment, which is certainly best practice at patient side, so damp wiping or dry wiping, that's going to significantly reduce the soiling and the bioburden. So you'll have a little bit more time before you can actually then move into the manual or the automated cleaning. So that's why we encourage that pre-treatment. So I would suggest that you wouldn't probably have very soiled instruments sitting around for any longer than 15 minutes. I'd be keeping it down to 5 or 10 minutes. So pre-treat or come through if you can straight away and rinse those items. Better still, if they have to sit for periods of time, think about some of the pre-treatments that you can now buy that come in a spray or a foam that you can put onto instruments. They're terrific for those who might be doing home visits or going into residential care facilities, where you can put them into your dirty container. You can apply the pre-treatment and they set, each product will set a maximum time to reprocessing, and some of them are as long as 12 hours, 24 hours.
Yeah, great advice, thank you. Does specific contents mean that every instrument needs to be identified? For example, forceps, scissors, etc.
If they're a single item, yes. If it's a tray or if it's a pack, you can say, oh, we've got 3 suture sets. And then you would have almost like a treatment instrument plan that in your suture set, it contains 1 pair of fine scissors, 1 needle holder, for example, so that you know that in that particular tray, that's what those instruments are. So then you can just record the number of trays. Or if you had single items like scissors, they were fine scissors, you can say there's 6 pairs of fine scissors. But you do need to record it.
Identify, exactly. I'm not sure if you'd like to pass comment on autoclaves that recycle water versus not, and how potentially will this be affected by the new standard?
I don't think I'm probably equipped to answer that question. I am aware that there are systems on the market now. It's all about that sustainability and actually from very reliable brands as well. So for me, I don't really want to give you an answer now, but my advice would be look at the systems that are available and really read through and get a good understanding of their working. In terms of the standard, the current draft new standard, there isn't any mention. It just refers to, sterilisation equipment or washer disinfectors. So water is water quality is a whole new area, an evolving area as well.
Yeah, correct. Thank you. You did allude to the next question, which is around how long should we store sterilised items for, and when should they be re-sterilised?
So when you look at the literature, and I did look at some literature in preparation for this evening, the studies have shown that it's event related, not time related. So as long as you store your items correctly and that they're not subject to contamination, then they should technically be able to last forever. However, we do know that if we don't have the right storage requirements or an event occurs where the integrity is impaired, then we need to reprocess those items. But look at simple things like your packaging. Whenever you open a sterile item, a reusable sterile item or a consumable that you've purchased in, you look at the packaging and you make sure that it's intact, it's not wet, it's not discoloured, that the laminate hasn't crinkled, and if any doubt, you know, you reprocess, you don't use it, you check that the indicators have changed colour as well.
Excellent. And again, I think like you mentioned, Megan, it really is about, you know, if you've got instruments that you're not using regularly, then why have you got them? Are you better off potentially going to a single-use item? So thinking about that. And again, have a look at the resources in the IPC guidelines, because I think people would be very surprised, you know, when you do that cost analysis. We've got a naive question here. I would say there is never any naive or silly questions, but the question is full compliance common in general practice? I'm fairly new to practice nursing and was surprised with what I have seen, or sadly not seen. Not sure what's meant by full compliance. Would you like to pass comment there, Megan?
And I can only comment from my experience, and that is that there is always room for improvement. I think can be difficult. I think there are challenges out there in being able to meet full compliance, but I do think that probably the great thing about the revision of the standards to guidelines is that everybody's reading them. And you're almost doing a gap analysis and actually identifying that there are areas for improvement, and that we need to be working towards full compliance with the current standard, but also being aware that we're also in that transition process as well. So yeah, I think in most practices that I see, there is always room for improvement. And some practices do it much better than others.
Correct. And we would certainly back that statement. I would say from an IPC audit perspective, reprocessing, there is always feedback that we can provide where there is that opportunity for improvement. And again, just remember, with everything that we're doing from an IPC perspective, we're taking that risk-based approach. So you've got to do your risk assessment when we do these. Now, I'm going to throw in a couple more questions if that's all right. We seem to have held on to most people. So the next question is around, can anyone tell me how to check a sonic cleaner daily?
Okay, so the first thing there, Amy, is that you need to go back to your manual, your ultrasonic cleaner manual, because the manufacturer's instructions will stipulate what the requirements are for your brand and type of ultrasonic cleaner. There are certainly some standard checks, and that's around dials and lids intact, baskets not corroding, that it's cleaned, that you do your performance testing in terms of your transducer testing, that you do your degassing, and that you record all of that. So the best thing to do, if I go into a practice, the first thing I do is I pull out all of the equipment manuals, and I read through what the requirements are before I actually even commence the audit, because everyone has it a little bit differently based on their type and brand of machine.
Excellent, thank you. I'm going to combine the next two questions, because really it's around processes. And so the first one is around, does anyone else's reception staff perform sterilisation procedures? I'm going to just make a statement to that, and if you look at the guidelines, as long as the individual has received the appropriate knowledge, skills, training, and is competent, and that competence is maintained, it does not have to be a clinical person that actually completes your reprocessing, but they must have received the appropriate training and skills and maintain that competency. Now, we know that particularly in general practice, what we often see is there'll be one individual, they may be a clinician, that teaches everyone else. We are expecting that to change in the revised standards. So can they do it? Yes, they can. Have they got the appropriate training to have done that? That's the question that you need to go and ask. Anything you want to add there, Megan?
No, I agree. I've had some very good admin reception staff who've been
Correct.
terrific at reprocessing, but they've all had the appropriate education training and are competent.
Totally agree. And I would say in our clinic, certainly the 2 IC that we had was probably far more skilled and qualified to perform our reprocessing process than what some of our newer nurses were. So most definitely. And I guess that comes back to spread the load of the responsibilities of IPC in your clinic. It doesn't have to fall on one person. If someone's got a particular interest in an area of IPC, let them take the lead on that and let them, you know, develop the skills and knowledge to do that. And then the second part of that is around, should reprocessing facilities be located in their own room, or is it appropriate to have a space set up in the treatment room? Do you want to take it on?
I know this is a challenge.
I know what we'll say.
Lots of practices, but reprocessing must be carried out in its own room, and, you know, even better, a clean room and a dirty room. But if it's in one room, it's that unidirectional flow. It shouldn't be being carried out in a treatment area.
Yeah, perfect.
Got to think about the movement of people, the
Airflow.
Yep, airflow. Yeah,
exactly. Gemma's asked, is there companies or services that can go through a hands-on in service on the reprocessing processes for staff education? It is challenging to find companies to come out. There is certainly courses that can be done, particularly in Victoria. There is a great one-day course, and we will share that information as part of this webinar. In saying that as well, watch this space. APNA is working around providing some additional resources, hands-on videos type things in the next, I won't say coming months. Let's go 6 months, shall we, Megan? Let's give ourselves a bit of breathing space, because we know this is a gap in the market, particularly for primary care. And so tonight's webinar is the first step in that process, as to we're looking at how we can support primary care to actually provide that education for you. Now, I'm very aware that it's...
Can I just add there too? Reach out to your suppliers and your product reps in the interim, because they can actually be really helpful. You know, the company, the supplier of your ultrasonic cleaner, they will often come out and do in-services, and that includes the chemicals as well. You know, your service provider, your technician who services your sterilizer, or the company that has sold you, they will come out and do in-service, and that will be very strong within the revised standard, or the new standard, is that we use these people and get them to come out and do in-service, and they do it on a regular basis as well.
Excellent. Thanks, Megan. Now, I'm going to go to the last questions, because we are just about at time, but we will address anything that we haven't got to tonight in the Q&A document. And sort of Janine and Yvonne are asking similar questions, in that Janine's saying, we outsource to a local hospital CSSD for the sterilisation of our utensils. We clean the utensils and then put them into a box, but this box is not picked up for 24 hours. Is this a problem? Second part to that, I think, is Yvonne's on a similar line, which is, can you use a holding tank until time is available to complete the cleaning process? The instrument would be firstly wiped of visible contamination.
Okay. In terms of the outsourcing, I would suggest that the 24-hour period is a little bit long if you're not pre-treating them. Now you're saying that you're cleaning them, but I don't know if that's manual cleaning or an automated cleaning process. If it's good, thorough cleaning, it should be okay. But I would probably also think about maybe using one of these pre-treatment foams or gels, especially if the items have got to sit there for that length of period before they're picked up. So there's probably some more, alternative or additional options that you could add in there.
Yeah.
And then the second question,
it's around the holding. Can you use a holding tank?
we we don't, only for short periods of time. They become like microbial soups. This is how I like to describe them. I think the longer things sit around, the more the microorganisms are that are present, particularly in a wet solution. We do know that a lot of bugs like to be in wet solutions. So keep it to a minimum. Certainly do your pre-treatment and then keep that soaking to an absolute minimum.
Excellent. Thank you so much for that, Megan. And look, I'm going to pull to a close now. You'll see on your screen a scan code. Please scan that and give us your feedback on tonight's webinar, along with what else you would like to see in this IPC space. I did mention that there is a number of resources available to you, and we will get those out to you in the following week, along with the recording and any additional education that's available to you. I also welcome you to, if you're interested in joining the Child Information Sharing Scheme webinars that are coming up, have a scan of that code and join us. And that is certainly, again, a Victorian project. Other than that, I thank you for joining us this evening. I thank Megan for her amazing knowledge and skills. We would absolutely be lost without Megan in the IPC program. Like I said, watch this space. We do have some exciting things coming to support you. And again, I'd like to thank, obviously, the Victorian government and Murray PHN as the lead for the Victorian PHNs in supporting the Infection Prevention and Control Helpline. So tonight's not the end of your support. If you would like ongoing support in any areas of IPC, you can certainly reach out by either calling us or sending us an email, and we will support you around policies, procedures, all those sorts of things. If you've just got an IPC question, reach out. That's what we're there for. Other than that, thank you again, Megan, for tonight. It's been a huge webinar with lots of information. And thank you to the team, to Lisa and Deb, for joining us and providing the support and behind the scenes. We'd be lost without them. So have a great night, everyone, and we look forward to seeing you at the next webinar. Thank you.